very interesting, and this gives you an idea about how rich is the dialogue in Uruguay. And now I will give the floor to our colleague Antonio Giuffrida, and we would like to know if in Europe and Central Asia the dialogue is at the same stage, more delayed in relation to Uruguay and Costa Rica and other countries, or more advanced. Please.
Thank you very much, Joanna, for the introduction. And I'm aware I'm the last person between you, the final conclusion, and the lunch, so I'm going to be very brief. And let me try this. So, and I take the opportunity to talk about the region where I work, Europe and Central Asia. Before joining the ECA region 1 year and a half ago, I worked for several years in Latin America and the Caribbean, a lot in Colombia, in Brazil, so country that I know the issue of health rights and judicialization, it's really important. So when I was asked by our colleagues at WBI to participate in this seminar, obviously, I wanted to see what is the difference between Latin America and the Caribbean and the ECA region, and why in the ECA region, obviously, the issue of health right is important, but why the issue of judicialization also is not so strong as it is in Colombia, in Brazil, countries that, as I mentioned, I know quite well. So basically, yesterday when I was preparing this for this seminar, so I was look a little bit of the literature and try to see what is the situation in the countries comprising Europe and Central Asia. I'm talking about the World Bank countries, so I'm not looking at the countries related to the European Union, but more the less developed countries. And what we can see is the situation is extremely heterogeneous. So I was looking at the studies published in The Lancet that look at the situation of right to health globally, and that just selected a country in our region, in Europe and Central Asia, and tried to summarize the various dimensions, which comprise from the recognition of rights in the Constitution, international treaty, the quality of health information related to the epidemiological, to the situation obviously of the countries, whether the country has a national health a plan that identifies the priority setting, a methodology for priority setting, and states' right to health, access to medicine, whether there is an essential list or whether really access to medicine it's real in the countries, and so also health worker rights, health financing, whether really the benefits package is financially sustainable in the countries, and also safeguard relation to information, health information, and basically in the patient right. And as I mentioned, the situation is extremely heterogeneous in Europe and Central Asia. So we have a group of countries that, according to the various indicators, reach the number is 15, but what does it mean? It's basically just comparing with, it's comparable with the most advanced countries. I was looking also France, United Kingdom, Germany, Italy. They all score between 15 and 17. And so we have a group of countries like the Czech Republic, Slovenia, Hungary, Macedonia, Bulgaria, that really score well, around 15 and also. Then we have like a middle group, like also Russia, Ukraine, Serbia, which is a bit lower, around 13, and a group of countries that definitely where the issue of health right is an issue. And we are talking mainly about the country of Central Asia and the Caucasus. So, bottom line, yes, the situation of right to health in the Europe and Central Asia is an issue. And it's quite interesting also, and the situation is very heterogeneous, but then also it's interesting if we think actually the situation not so far away, about just more than 20 years, was much more homogeneous. Before the Berlin Wall, all the countries in the region have a very similar system in terms of right to health, where access to health was essentially all free, at least according to the law, to all citizenship. But obviously what we observe in the last 20 years is a different pattern, so which actually I think is also reflected by the data I showed before. So basically we see a group of countries that saw the European Union as their objective. So obviously among the countries we are countries that are already part of the European Union or part of the country that aspire to be in the European Union. So obviously most of them, including the legislation, law, practice, rules and regulation, a lot of the right to health included in the European Treaty and practice in the European countries. Then we have a group of countries, as I mentioned, Russian Federation and also Ukraine, Belarus and Moldova, that are not so attracted by the European Union, but they have quite good health right. At least on according to the to the indicator where we have. And then obviously the third group of countries, the Central Asia, Caucasian countries, where the reality is much different. And obviously there is a number of issues, then we're going to look very quickly in the next slides, why also these countries are particularly where access to health and rights to health is particularly problematic. So I just wanted to focus on what I think are the main key issues to right to health in this region, but I think also relevant to other countries in the world, to also Latin America and the Caribbean, and actually the issues that we discussed in the previous session. The first one, which I think is extremely important in all these countries, is really the financial gap between what is the statutory package in the state guaranteed benefit package of these countries, what is really the financing available. And this is particularly problematic again in Central Asia and in the Caucasus, where public health is around 2% or sometimes 2 or 3% of GDP. In Russia is around 5%. Obviously, the new European EU countries, it's almost around 7%. And this obviously explains why the difference to having a real right to health. And especially in the country in Central Asia and in the Caucasus, the results is in informal payment. So the health system needs to survive. So really the coping strategy almost of the system is to ask for informal payment to the user. The other issue is access to medicine, and especially access to medicine in ambulatory setting. Most of the state guarantee package provide drugs in inpatient setting, but very limited provision in ambulatory setting. And the other issue is related to specific subgroup of the population, and some that are particularly problematic is the case of undocumented migrants, especially in Russia, coming from Central Asia or the Caucasus, the European Roma population, and obviously in Hungary, Romania, in the east part of Europe. Other problematic area are specific health conditions, like the situation of mental health, tuberculosis, and the way they are treated in their institution. Especially tuberculosis is still a practice in several countries, basically to rather than having like more modern treatment like DOTS, to rely on basically on inpatient setting, which is not good from the patient, but neither for containing the disease actually. And the other element, which actually I think is a key difference for some of the countries in the region and the Latin American countries that we saw today, Uruguay, Costa Rica, Brazil, is obviously the issue of the role of the judiciary. In some of these countries, really, there is not an independent judiciary. The judges are appointed by the executive, so obviously you don't have this tension between the various elements of the country. So these are just some thoughts from my new region, Europe and Central Asia, which I hope that are also relevant for Uruguay. Just to conclude, also, obviously, what I think is very interesting in the Uruguayan model is the capacity of the dialogue between the various stakeholders. Because obviously, as we say in economic terms, in this specific issue, the asymmetry of information is huge. And so it's very important, obviously, to have a very rich, continuous dialogue to make everyone that is part of the decision-making process, starting from the patient who asks for the drugs, the doctor who prescribes, the health institution, the Ministry of Health to decide, provide guidelines, the financing aspect, and the judge finally to know what are all the implications of the decision. And obviously the question is, this model looks like it's worked quite well in Uruguay. But obviously Uruguay is a relatively homogeneous, small country where this is easier. And obviously the question is how to make this model working in bigger countries like Brazil, also Colombia, I mean, where obviously it's more difficult also to have this type of dialogue. Okay, thank you very much. And now final remark and then lunch. Thank you.
Thank you very much, Antonio, for the very nice presentation and for being brief. So we have come to the end of the panel. I think we have heard a very interesting experience in Uruguay, also in ECA. Before we heard in Costa Rica and we heard about Brazil. My suggestion for those of you that have not done so is that this information is published because it's really a very rich experience that you have, very interesting and that can be useful. I'm sure in Latin America and the Caribbean we have the exact same three groups that you identified in Europe and Central Asia. And so countries that are much more delayed in relation to launching a national dialogue could benefit very much from this, and maybe WBI can help in these publications of these case studies. Thank you to all, and we will continue this work with WBI. Thank you very much.